Welcome, everyone. Hello, thank you for joining us for this presentation today, Optimizing Critical Access Hospital Reimbursement in an Ever-Changing Regulatory Environment. My name is Cassidy Avila, and I'm the Program Coordinator for the Texas A&M Health Rural Engagement Program. We are recording this webinar, and we'll share a copy of the recording with you later in a follow-up email from the Rural Engagement Program. So I think we'll just jump right in. It's my pleasure to be able to introduce our speaker, Dan Larson. Dan is a principal with the healthcare group of CLA, specializing in consulting services in the area of revenue cycle improvement, financial analysis, and Medicare and Medicaid reimbursement. Dan leads the critical access hospital reimbursement consulting practice. He has more than 29 years of experience in public accounting, mainly devoted to the healthcare industry. His current consulting work includes various forms of reimbursement and financial analysis, including critical access hospital performance benchmarking, critical access hospital gold standard benchmarking, reimbursement strategy sessions, charge master assessments, practice opportunity studies, and many, many more. So Dan, we are so grateful for your presence here today and your experience, and we are excited to get started. So I'm going to go ahead and pass it over to you. Oh, you're still muted.
Appreciate that introduction. I knew I was going to forget to turn that back on.
I do it all the time.
We'll go ahead and get things started here. It looks like we have a few folks online. As part of this, just as an FYI, I've got some slides and presentation here to pull up, and I'll pull that up shortly. But if anybody's got questions, we want to make this more of a conversation, I'm totally up for that too. So please, speak out as you go, or if you've got questions that are out there. And I don't know, Cassidy, if you're going to be monitoring the chat box, but if you are, if there's something out there that I'm not seeing, please let me know, and I'll try to keep it up on the right side as well myself. So
absolutely.
Let me share the screen. Should be my full screen here. Can everybody see this okay? Okay. So as Cassidy mentioned, we're asked to kind of do some critical access hospital reimbursement strategies and context on how to optimize critical access reimbursement as a facility. Oops. One thing I will say, we just have to put that out there, is trying to present on the regulations as they are today, but as we know, especially in these days with the new federal government, things are changing on a regular basis. So what might be true today might not be the same tomorrow. So regulations and auditors and how they react to things could change tomorrow. From a learning objective standpoint, we kind of broke this into three different things. One of my key items is I want you to be able to have just a better idea of what's going on out there from a regulatory standpoint. More importantly, I want to make sure you have an idea of what you can take back to your facilities to strategically help your own facilities, or things to look for. If there's 2 or 3 things you can take out of this to go back to your facilities and look at to see if there might be some opportunities, I think that's key for each of you. And so if we can provide that value to you, that's kind of CLA's way of helping provide that value to take care of your healthcare patients there down in Texas. So we kind of look at it that way from a healthcare professional standpoint, is if we can do that, that's our way of serving you all. So, and actually, I'm going to try one thing real quick here. I'm going to change my view a little bit. Just trying to figure out how to share this screen right. So, all right. So as we go through it, I'm going to start out just with some basics. I'm assuming we've got mostly critical access folks on the call here from a critical access hospital standpoint. I'm going to go through it. I've always found it helpful when we do these discussions and we talk strategy that we go back to the really, really basics and talk about what is cost-based reimbursement and how does that work. We'll go through some common areas that we potentially see some opportunities out there. I do have some information and an example of, what do we do about non-reimbursable or non-cost-based areas in our facilities? And if we were to eliminate those, what would that look like? Or how do we go about analyzing whether we should continue those programs? And then a little bit on just protecting your cost-based reimbursement at the end. I think a lot of the uptime we'll try to spend on the opportunities and reimbursement opportunities that are there. And I also want to make sure as we go through that, I'm going to throw in just some things I've specifically been seeing out there in Texas for some of the Texas facilities that we work with and have been working with in the last few months through the Texas A&M group here. So we'll make sure we share some of that knowledge that we've brought together there. Why is this not going? There we go. So what does cost-based reimbursement really mean? When critical access reimbursement first came out, everybody's, oh, everything's cost-based, everything's paid for. The CEOs got all excited and everything's gonna be paid for 100%. We love it. This will be great. And as we work through that, it's kind of like, no, only Medicare's portion of that's going to be paid for. Let's start thinking about that. From a reimbursement standpoint, when we think about the PPS and the DRG side of things, that your cost base per day instead of a DRG payment for the PPS side. So you're basically getting your cost back per day, but how we report those days is going to be really important. We're cost based on the outpatient side for outpatient reimbursement. We get paid on a cost per day upfront for the swing bed reimbursement. And one thing to remember, these are all Medicare, straight Medicare, general Medicare, and this isn't necessarily Medicare Advantage. Medicare Advantage is supposed to pay in similar fashion, but they aren't always there. One thing that I've seen out there recent information on, and to the extent that any of you can all help push this through, currently for coinsurance, critical access hospital patients are charged 20% of charges on that coinsurance side of things, versus it's really 20% of the APC payment or fee schedule payment if you're a PPS hospital. So as we work through those, you think about that, 20% of charges, say for a CT scan, where I'm getting charged, $3,000 for a CT scan, that might be a $600 coinsurance number. 20% of the APC payment that a PPS hospital gets might be 20% of $300, which could end up being a $50 coinsurance instead of a $600 coinsurance. So there's a significant piece there. There was a recent MedPAC decision to recommend that they look at that and look at the impact on beneficiaries in rural areas. And they're recommending to CMS that they consider switching this 20% of charges to 20% of the payment. So I think would be 20% of your interim rate on the claims as they come out, or those interim payment rates would be there, which would definitely put you on a much better playing field as far as the impact of beneficiaries go from a critical access hospital, especially if there's PPS options just down the road. You do have, as a critical access hospital, the option for method 2 billing, which is worth an extra 12% on your fee schedule reimbursement for your providers if they're provider based. So that's good to know. From a cost report sensitivity, on a PPS facility, there are certain things that are really critical, but there are also that drive that settlement. But on a critical access hospital, there are a lot of points that would drive the settlement for you guys or for you folks. You do have to deal with the 96-hour length of stay. Revenue codes from a charge master alignment standpoint really matter, and we'll talk through that and why that's there. And is either one of them a license to spend? No. I oftentimes when we think about financial decisions for a critical access hospital, the methodology as you think through those should really be no different than you would think about it if you were a PPS hospital. You still want to be efficient. You still want to raise revenue from third-party payers. Still want to do all the exact same things. If you can grow volumes, that's great. If it pushes down your cost to charge ratio, that's not an issue. So as we look through it and talk through that, this is just an example of how we look at just the routine cost or the cost formulas for the cost report. So I would say at the end of the day, there's thousands of numbers that flow into the Medicare cost report from a cost reporting standpoint. But this is just a simplified look. So if we look at it, this is the routine side, meaning like the nursing floor component of it. So on worksheet A, we have the direct costs. So we take those right off of trial balance. So we might have housekeeping costs and maintenance costs and administrative costs and We've got the direct costs in the different departments. In this case, we'd have direct costs in the adults and peds floor, basically the nursing costs on the floor. We fully allocate or we allocate down any of those overhead costs based on different statistics and things that are out there. So we take those costs and run those through a step down to get those allocated out. That might be on square footage. That might be on charges. It can be just some different methodologies that are out there. You have the ability, if you request those, to customize those statistics. And in some cases, it makes sense to use a simplified method of statistics to allocate those. And we can talk about that a little bit more later as well. We've seen some positive pickups for certain facilities in those situations. But after we allocate those out, we get the fully allocated cost. And then for the inpatient side, for the routine portion of care, we get that, and we divide it by the number of days. And one important thing I would tell you is when you look at the days, it's inpatient, swing bed, and observation days. Those three criteria can tell you a lot about where your settlement's at which direction it's going. If those three are going up, your cost per day is probably going to go down. You might have a payback. If they're going down, your cost per day is probably going to go up, and you may have a receivable. One key part of that is understanding which swing bed days count in that formula. And as we look at those, it's really critical to be able to identify specifically your Medicare swing bed days and your Medicare Advantage swing bed days. Those are both included in the denominator, and any other payer is not. Those are just carved out at a different rate. We've seen some issues on some of the cost reports that have been out there where we're not identifying the Medicare Advantage ones correctly, or we're missing some of those components, but that's critical. So then we get the cost per day. We take that times the Medicare days off your PSNR report that you sent in, and it's sort of like a tax return. We calculate the Medicare cost, and if we pay too much, they pay us back. If we pay too little, we have to pay money in. If we look at it from the ancillary side, there's not really any common statistics that we can really follow from an X-ray or MRI or lab side. There's too many potential statistics out there. So instead, like we would have with days is inpatient days and inpatient day. But in that case, they use charges. So we get the fully allocated cost. We get our total worksheet C charges to calculate a cost to charge ratio. We take that cost to charge ratio by the times the Medicare charges. And one of the key things that we'll talk about this is off your charge master is understanding how do I line up insurance codes, the revenue codes or the 3-digit code that goes out on your UB, and how am I lining those up to the claims? Because if I don't get those lined up correctly, I'm not going to get paid correctly. For instance, IV administration is a 260 revenue code, but that's not the same as IV solutions under 258. So one of those might get lined up against the drug cost to charge ratio. One of those might get lined up against the ER cost to charge ratio, which might be much higher. But anyway, in case we get that cost to charge ratio, we multiply that times our Medicare charges at each one of those individual line items for lab and radiology and ER and all these other cost centers, operating them, et cetera. Calculate Medicare cost. We compare that to what they paid us, and we have a settle up. One common question, I can't really see everybody's hands on this one, so I won't look for those. But I always ask the groups, should your cost to charge ratio be higher or should it be lower? And the answer that I'm looking for is, well, when we prepare your cost report, we want to make sure we can show them as high as we can. We want you to get credit for those as much as you can. However, operationally, you don't necessarily want really high cost to charge ratios because that means you're either not being efficient or your volume's too low, or maybe you're not pricing appropriately. So operationally, you actually want those to be a little bit lower. Maybe not too low, but you want them to be on the lower side. Another way to look at this from a step-down standpoint as we walk through things is this is just a simplified version. We have these capital cost centers. We get them allocated down. But what I wanted to show this is really at the end of the day, when we think about it, Medicare at the end of the day is paying their percentage of the cost of each of the cost centers. So based on days, they pay their percentage of cost in adults and peds. Based on charges, they'll pay their percentage of cost in the ER. Based on visits, they pay their percentage of cost in the rural health clinics. So going back to my algebra days, which that's probably the only math I used from high school and doing as a CPA, believe it or not. I don't use calculus or all those other things. We don't need to do that. But when we go back to that, if we think about it, the cost to charge ratio, whether it's higher or lower, really doesn't matter. if we take total cost over total charges times Medicare charges to get Medicare cost, that's the same formula if I flip the charges over to say I take my total cost for that department times Medicare's utilization or percentage of that cost. And that's a critical thing to be thinking about as you're thinking about making decisions in your facilities. So this is an example of what we would typically look at for utilization percentages. This is from an actual facility that's out there saying, okay, what percentage of each one of those costs is getting reimbursed. This one has very, very high Medicare percentages in it, very small facility in a really remote part of a state. These are probably higher than you would normally see in the average facility, but it's a live example of one that was out there. So this is saying basically an operating room is about 77% of the charges were actually Medicare charges in that situation. It's interesting if we look at anesthesia, I would expect that to be fairly similar, but there's something going on where it's just a little bit different. If we look at other examples, I think, can you see this Excel file here? Is that showing up correctly? Cassidy, can you see this?
Yes.
Am I on the right screen? I just want to make sure I'm on the right screen over here. So this is actually an example of our monthly settlement template that we use with our clients. I think it's got some different examples in there I just wanted to share with you. But when we look at these, some of the areas to look at your provider-based clinics that are out there. And you look at the Medicare percentages that are in those clinics. And you would want to look at those and say, okay, do those make sense that Medicare is 32% or 36%? When we look at labs about 30%. That's a pretty good indicator of, radiology is about 30%. So between those, that's pretty similar to those clinics. One thing to look for as you go back to your facilities is look and see, are those, do those Medicare percentages of total charges make sense when I look at other departments within that facility? In this case, they do. We have seen several instances recently where we're just not seeing that, which means somebody did something wrong either in the cost report alignment side of things or billing side of things potentially, or maybe missing a component of the billing. And actually in Texas, we've seen multiple issues where the provider-based clinic percentage was showing up as 0 or close to 0 because the facility component wasn't being billed out on the UB properly with like a 510 revenue code. I've actually also seen, unfortunately, in a couple other states throughout the U.S. where that number is 80%, and it didn't make any sense. And it's because they didn't adjust charges correctly, or they did an adjustment wrong throughout the cost report. And a couple of those situations, they had paybacks that were in the millions when you looked at it out there. So keeping an eye on those percentages to make sure they make sense really is important when you're looking at your own cost reports as you're following those through. But if you look at this, one thing you'll see is these are all the revenue producing departments. But what about the non-revenue producing departments? How do I know what my percentage of Medicare cost is being recovered from my housekeeping area? So one of the things we advocate doing, and we do this as a part of our step down process that we do when we do our cost reports that we prepare, is we look at it and say, okay, in these facilities, if I put $1,000 in any one of these cost report lines, what does it do to the settlement? So that steps it all the way down through the cost report to those different revenue producing departments. And then it gets allocated between all of those at different rates, and they all get paid at different Medicare percentages. But in this case, what it shows you is, okay, I've got a business office that I've got a business office that it's set up that I'm allocating maybe based on charges or based on another decision. In this case, this facility happens to have a skilled nursing facility, which was drawing down quite a bit of overhead to it. By setting up the business office, we avoid allocating some of those administrative costs to the nursing facility, and we end up allocating them to other areas that are cost-based. So by setting that up, I can get paid 53% of my billing costs. And they have got separate billers for the nursing facility. By doing IT costs based on number of users, I might get allocated 30% of those costs. I get paid by Medicare. And that's different than, potentially if I left it all just in one administrative and general bucket, I might only get paid 24%. So that understanding the percentages matters, and where you book the accounts payable, where you book those expenses really matters as you walk through those from a facility standpoint. So having this in front of you, I think, can help. The other thing that this can be helpful for is, I might have decisions about, most of my dietary meals are for my nursing facility. So because of that, I have a very low cost-based utilization percentage in dietary in this cost center. But I do know that I've got people in the serving lines that are actually in the cafeteria space serving meals to my employees that aren't involved in that meal prep. So if I take the time to break those costs out, I can get paid at a higher percentage for those facilities or those individuals. If I put in other places, this one, social services, is only working in the nursing facility. There might be a question: is that really true, or is there anything else going on there? So having this in front of you, I think, helps. The other thing you'll see is that, if I've got non-cost based areas, and by the way, we can talk a little bit later maybe about ambulance, there's some opportunities, I think, for that to be cost based. But if I got non-cost based areas, if those areas draw overhead through that step down process, and because they take it away from other cost centers where it would be reimbursed, I may have a negative percentage. And these percentages off, the minus 2% is a pretty low percentage. I see those as high as 10% or 14% negative, meaning if I add additional, cost centers that are down here that aren't cost based, it could be fairly detrimental to my CAH reimbursement. I see a question that will we get the slides? Yes, Alan, we'll make sure to get the slides out to everybody there. Apologize for not getting those ahead of time. So let's talk through some common things that we see just from a cost report opportunity standpoint that you can maybe look for, kind of given some of the things that are up top there. So as we walk through these, some of these are, avoiding, you'll hear me use the terms of, duplicate cost allocations. So there can be situations, I'm going to actually step back a slide here. There can be situations where I have, say, a rural health clinic that's only getting paid 9% incrementally of my Medicare cost, where maybe I have a billing individual that's directly coded to that rural health clinic. But then through the step down process, I put some additional, I have hospital billers up in the business office, and those get allocated down to that rural health clinic a second time. That's what we kind of call a duplicate allocation. So now I've got, more people there for billing than I should have had in total. We'll walk through some other capitalization areas, policies that are there as well. Let me get to the duplicate allocation. We'll kind of come through some of these components. So all of them are pretty common areas. So, many of you might have rural health clinics. I know it's fairly common to see that in Texas, rural health clinics that are attached. A lot of times, if those rural health clinics are off-site from the facility, you might actually just contract with somebody locally to do the housekeeping work for that facility. Might be an independent individual or a company that you're contracting with, where that cost gets coded directly to that rural health clinic. And depending on whether you're above or below the cost per visit limits, that can come into play, whether you get reimbursed anything or actually you just generally rural health clinics get reimbursed at a lower Medicare percentage or lower cost-based percentage than other facilities or other departments. But if your main housekeeping cost center then also has square footage listed for that rural health clinic, you end up having direct costs and housekeepers that are really working in the hospital getting allocated to that rural health clinic, and you get that duplicate allocation of costs, which causes you to get paid at a lower rate for those costs, which means you basically would leave money on the table. So those are things we want to look at. Oftentimes the rural health clinic may have separate business offices or billing folks that are out there. And those expenses, it's not uncommon for those to get combined in the labor distribution reports or directly coded to the rural health clinic departments on a cost report that show up there. And you can look on your cost reports. There's an M-1 work paper that shows that if you see a lot of administrative expense there showing up on that M-1 work paper towards the bottom, there could be a very good chance you've got some duplicate allocation going on with your administrative costs. Because if I've got billers or receptionists or other folks there and I'm allocating additional costs down to it, I'm hitting it twice, and I don't want to do that. I've got a note here saying don't forget square footage. So if we think about it, a lot of times when we look at cost reports, what we find is on the rural health clinic side of things, we in the hospital, we go through the square footage and we say, this is the business office area, this is the reception desk, this is the finance person's office, this is housekeeping's closet, this is my lab department. We go through all the detail to do that. I commonly see when you've got an off-campus rural health clinic and you ask the maintenance person, can you go get the square footage for the rural health clinic? They might look at it and say, well, it's 60 by 60, so it's 3,600 square feet and it's all rural health clinic space. But they're not thinking about the fact that it's not really all rural health clinic space. Inside that rural health clinic, if I thought about how I broke out my square footage on the hospital side, I've got a reception area, I've got public bathrooms, I may have hallways, I might have the billers area, I might have a coder sitting in that rural health clinic department, I may have all those other different areas of square footage. If I take the time to break those costs out, instead of getting reimbursed at the lower percentage that I might be getting reimbursed at, in this case, 9%, maybe if I move those costs back up to these different departments, I might get 50 cents on the dollar for that square footage cost, or I might get, depending on where I put my receptionist, maybe 25 cents on the dollar. But I'm incrementally going to pick up dollars by breaking that square footage out and handling that square footage correctly throughout the cost report. Hopefully that makes sense as we look at that. And especially you want to look at what am I allocating to non-cost based areas. If I've got home health, or if I've got rural health clinic, which is a low cost based area, or if I've got an ambulance and I don't have it set up as cost based, you want to look at those costs and understand what's in those and what overhead costs am I allocating to those. And you want to make sure you're not doing duplicate allocations of those, because that's a pretty easy fix and a pretty easy thing to spot from a reimbursement standpoint. Some other things that, may be minor, but one of the things we always say when we prepare cost reports to our new preparers that are there is, if you may have audit experience, but audit materiality doesn't really apply to cost reports. If you find something that's worth $1,000 and you fix it, it's worth $1,000 a year. It's not just worth $1,000. It's going to be that $1,000 a year going forward. So some common things that we see, like an offsite or rural health clinic, or even an on-site one, they may have their own phone bill, or they may have their own phone lines coming in. Oftentimes those get grouped to the departments, but if we think about that, I might not be breaking those out for anybody else, and all my other hospital ones are sitting in my administrative department. I want to watch out for those. It doesn't seem like they're large dollars, but they can be fairly large dollars. The other thing to look at is it may not even be phone expenses like your traditional phone bill anymore, because really your IT costs maybe all be bundled into one IT service, which includes your internet access and everything else that goes with that. So thinking about those, the receptionist cost is a pretty common one. Insurance oftentimes ends up that, we put some of the insurance directly in a rural health clinic or provider-based clinic or in a different area, but we put all the rest of the insurance in the hospital administrative cost center, and we end up stepping it down to that rural health clinic or that other non-reimbursable area separately, and it causes issues. Utilities, garbage services, housekeeping costs, billing software costs, all of those things are ones that are oftentimes we run into where we see some duplicate allocation of costs. And usually when we see those, they're getting duplicately allocated to a lower or non-cost-based area than normal. So most of the time when you're looking for cost-based duplicate or duplicate cost allocations, you're going to find positive opportunities from a reimbursement standpoint. So usually no harm to look for those. Some other things that you look for, I would call them hidden costs. As a cost report preparer, you can see a trial balance and you can see what's in that trial balance. And from my experience, this is a real live example. We have a client that said, we've got rural health clinic salaries and there's $400,000 of rural health clinic salaries. But what they didn't say was, well, I wanted to fully load my rural health clinic. So I had my maintenance people directly code their cost to the rural health clinic, and I had my housekeepers directly code their cost to the rural health clinic. And you can't see that from a trial balance standpoint. So those costs are kind of hidden in that general ledger detail as you look at those. And by looking at that, you can realize, well, if they're hidden in there, we don't know that. We end up stepping down and duplicate allocating to those, not even knowing that we're doing that. We really need to know kind of what's behind the scenes in that trial balance level, and we want to make sure we don't have things getting doubled up. So had one a number of years ago that they did this exact same thing, and they were missing out on $100,000 a year reimbursement every year because they wanted their internal financial statements to be fully loaded for the clinic, but they buried everything under a very general salary description. So one thing we've learned to do over the years is we'll pull labor and distribution reports all the time when we do these, because we want to see what's in there by job type and try to avoid those situations. Yeah, I mentioned that one was about $100,000 of opportunity that was there. Anytime you have any interdepartmental allocations, sometimes people do that with administrative costs, or they allocate things out. You want to make sure your cost report preparer knows what you're doing there, make sure that those aren't buried and everything's handled correctly on those. The home departments, and one other common area of looking for opportunities is looking at home departments. If you look at the Medicare reimbursable percentage for the average adults and peds floor is usually much higher than the emergency room from a usage standpoint. If I've got nurses that are splitting their time between those, I want to think about where do I put their downtime, or where do I base those nurses. I would rather have the nurses sitting in the adults and peds floor, helping out, helping restock things on the inpatient floor or whatnot, than just assigning 100% of their time to the emergency room. We've seen examples time and time again where the charge nurse thought in order to get the charge differential, or that extra 75 cents an hour or whatever they're getting for that they needed to code 100% of their time to the emergency room. And the reality is they were probably working in the emergency room, 10 or 15% of the time, because especially the night shift, there was, very little activity in those, oftentimes in a critical access hospital. That reimbursement, cost-based percentage can be 30 to 40% higher fairly often. Typically, we'll see it 30 to 40% higher. So if I have $100,000 that I can home base on an inpatient floor and float to that ER cost center, that could be $30,000 to $40,000 a year from a reimbursement standpoint. And we want to make sure we take advantage of those operationally. You can also look at, thinking about job descriptions and what those look like. There's different areas you can look at those. I probably have a slide on this later, but thinking about like marketing individuals. Do I have a marketing department? Well, a lot of times you might say I've got a marketing department, but that individual may be doing a lot of administrative work. If you look at their job description, that's actually allowable costs. They might be doing the employee recruiting and other things that we want to be aware of. So we want to be looking at those for potential opportunities as well. And leading into advertising costs, if we look at advertising costs from a cost center standpoint, this is an area where I do think that there's oftentimes opportunity. Generally, advertising cost gets offset as non-reimbursable in lieu of not taking the time to look at it. But when we go back to those reimbursement percentages, for every dollar I don't offset, I'm getting 25 cents on the dollar in this example. I might get 35 cents on the dollar, depending on what your Medicare mix is. From a reimbursement standpoint, if you look at the regulations that are out there, they basically say if it's connected with the public or provider's public image relations allowable, if advertising is primarily concerned with the presentation of a good public image, directly related to patient care, could be visiting hours, could be management, employee relations. One of the things that I look at is things like, I'm going to sponsor the local baseball team, so I'm going to, I'll do a $500 sponsorship to have our name out on the outfield fence. Well, is that allowable or not allowable? Well, somebody might say, well, that has nothing to do with healthcare, so we think that's not allowable. But the reality is, I would argue that's about being a good employer in the community. And if I'm a good employer in the community, it's easier for me to hire people, or there's a perception that I'm a good employer, and it's easier for me to hire people in my facility that are local and bring those in, which might save me some dollars at the end. And so I think some of those things, if you think about the argument behind them, I think you can find a positive argument there where you can have those costs actually be allowable. A lot of times I see them listed as sponsorships or other things. Well, the reality is it's really probably allowable advertising. Any recruiting of personnel, and I'll show you, this is actually for recruiting doctors as well. When you look at the reading on this, any of that cost for recruiting doctors or other professionals or overhead folks is going to be allowable cost that's out there as well, and that's an area that sometimes gets missed. The on the advertising side, they say yellow pages is allowable. Well, what are our yellow pages now? Our yellow pages really our internet website, and as long as you're not buying Google ads or Google searches to go find patients and drive patients, which I've not really heard of anybody try to do anything like that, where you're proactively going to try to pull people in. Any of that informational type of thing on your website, I think probably could be argued to be allowable cost. When you look at non-allowable, they talk about fundraising isn't allowable, but then if you do get contributions, you don't have to offset those. If you're asking doctors to come and use your facility, say, hey, come use our CT scanner, send your patients over here, those aren't allowable. But if it's for trying to recruit a doctor to be on your staff, work as a member of your staff, that is actually allowable. And then the general test is, if you say you put a billboard out there that says, hey, come to our facility, we're the best in the area, we're the best in the state, come seek medical care at our facility. If you're trying to specifically induce patients to come to your facility, that's where they consider those non-allowable, which makes sense because Medicare don't want facilities competing or spending money to argue over each and everyone's patients as they go through those. So I think common areas when we look at from expense adjustments, we oftentimes see costs that are getting written off that don't need to be for advertising. If you take the time to document it ahead of time, which way it goes, I would always have two accounts, one for allowable, one for non-allowable. Have that person that's in charge of that and documenting those. That's important. I also would probably not have a marketing department. I would just incorporate those into the administrative department and just offset the expenses that aren't allowable versus having a full-blown non-reimbursable cost center. Miscellaneous income accounts, common areas that we're seeing quite a few examples where if somebody sees a miscellaneous income account, they're offsetting that against expense. But the only reason you need to offset miscellaneous income against expense is if there's an underlying expense that's not related to patient care. So there's always a question about what's this for. And we commonly see third-party settlements end up showing up in miscellaneous expenses. Well, the cost behind those is really the care of those patients. Those are all allowable costs. There's really no need to offset those types of things. And so we don't want to offset those if we can help it. Let's see. Other areas we talked about marketing, we hit those. I think we're probably good there. I don't know if we have a lot of folks here that have home office cost reports or if they're part of networks in the group. We oftentimes, depending on where you assign those, there can be a benefit. Home office costs come off this home office cost report, and basically the related party costs get added. What oftentimes happens is they all get added to one administrative and general line. And if you think about it, a lot of times you might get billing services or you might get medical record services or other things through those. Those Medicare cost-based percentages are different, and as a result of that, you get paid at different rates. So there's an advantage about being careful about those. Collection expense, where are you putting that out there? Are you recording it as an expense, or are you netting it against your bad debt write-offs? Is it getting buried out there somewhere? When you look at that collection expense is no different than your business office internally, from an expense standpoint. That is an allowable expense. Make sure you're getting credit for those. That's important out there. Electronic health records, I kind of alluded a little bit at that on the home office side, but if I'm allocating it to medical records, I might get paid a certain percentage. If I get allocated on business office, I might get a different percentage. I could potentially bury that IT cost in admin in general and get paid another percentage. So you want to look at those. There can be more than one way to argue it. You could argue it's a billing and a medical record system, and it's just one fee, and maybe I put it in admin or maybe I put it in billing. You could also argue if I can have enough detail, I can break out the EHR side of it, and maybe I put it in medical records and I get paid a better percentage. Not sure if you run into this a lot, but security costs, if you've got we've seen some situations where you've got to hire or pay for the local security company or the local police to watch somebody one-on-one. If they're sitting in an inpatient room, I would be charging that to an accommodation cost center and getting paid at my adults and peds rate for those. Capital cost, depreciation policies, just make sure make sure you're looking at those. And there's a $5,000, you can write off up to $5,000 before having to depreciate it. I would probably have that, make sure that's your set policy, that you're getting the full advantage of that. One area that we do see, if you do have building projects and things happening, make sure you take the time to do as good of a job as you can componentizing those building projects out. If you do that, you can take what would be a 40-year life down to probably 20 years on average if you do a good job getting all the wiring and the wall coverings and the paint and getting everything broken out for those. Look at time here. I think I'm doing all right. A couple other things as we look through this. Every year we'd suggest when you look at your cost report statistics, in order to optimize reimbursement, you should sit down with your preparer and ask, do I have the right statistics? Am I allocating things correctly? Should I just use the simplified method of allocation, which is a very, just having really short list of but specific statistics that you have to use? Or should I break out an EHR cost center separate from an IT cost center? So I could have an electronic health records cost center as an overhead cost center and allocate that just based on, the number of individuals by department that have logins to my EHR. I could request that from a Medicare standpoint and have that added. So, by the way, any of the requests that you have, if you want to change statistics, you have to do those 90 days prior to the end of your cost report period. So if you're a 6/30 year end and you were looking to try to change a statistic for your 6/30/2025 year end cost report, you'd have to be thinking about that very quickly here and getting something in by the end of the month for those. So and for that request to hit this year, otherwise you'd be looking at it, the year after that. When we look at time studies, look at those things too, because we're seeing Medicare auditors increase what they're asking for. CMS is really directing them to be more and more detailed on things that they're asking for and the support that they're asking for. I would look at your statistic and say, is my medical records time study or my maintenance time study? If I'm using time studies, make sure that you are getting those once a month, alternating weeks. Make sure you're getting that detail behind those and you're breaking that out from a facility standpoint. Because if you don't do that, you're going to potentially leave some dollars on the table. These are just some ideas of, if I want to componentize A&G, these are some different cost centers to think about. Purchasing, one I hadn't mentioned, but maybe allocate that based on supply purchases by department that could push more cost to your inpatient areas or some of your higher Medicare areas. Other cost centers to think about componentizing. You can, depending on like dietary, you break out cafeteria, but depending on how you're set up, sometimes people have more than one dietary department. They might have two different locations. They might have more than one maintenance or housekeeping department that's out there. Nursing admin, I would look very carefully at how those costs are being allocated, and are they being allocated to the right departments that they're supervising or whatnot. We see some common mistakes there. Cafeteria meal counts, make sure you're being careful about those and that your dietary folks know how to count the meals. Including equivalent meals, taking your cafeteria meals and converting those to equivalent meals. If somebody comes down and just grabs a coffee, that's not a meal. And, we have to take a percentage of the cost of what a normal meal would be priced at and divide our revenue into that to try to estimate what the meal counts are. Let's see. Other common areas, thinking about square footage. One tip to look at is if you've got an emergency room drop-off area, where the ambulance might sit. If I've got two slots and an ambulance sits in one slot might be ambulance, but I would call the other one an emergency room drop-off. I'm going to get cost-based reimbursed probably at a better percentage for that. At least I'm going to get some reimbursement for that as long as I'm cost-based there. And looking at those areas that are there. Oops. Actually hit one too quick here. From a cost report standpoint, one of the things, or a charge master alignment standpoint, this is an area that we do see quite a few issues with. I mentioned early on that the revenue code matters on the critical access hospital. We'll kind of walk through this. From a charge master standpoint, from a best practice standpoint, we always, and we've gotten to this point, we just decided this is just part of preparation practice as a firm. But what we recommend is you get a copy of the revenue usage download each year. and the charge master, and you line up that revenue by revenue code, by department, to see exactly where those revenue codes are being generated. Are my IV infusions with the 260 being generated on the inpatient floor? Do I have a separate outpatient infusion cost center? Are they being generated in the emergency room department? Depending on where I put those, I get reimbursed differently for those. Do I have? Go ahead.
Dan,
Yep.
maybe just want to jump in here real quick because just so they can visualize what this looks like. If you make a table that has all your departments in rows and has all of your revenue codes in columns, it'll it'll come out plain as day when, oh, okay, this thing is definitely in the wrong department or this code's definitely in the wrong spot. It's a real, I mean, in terms of quick and easy analysis that anybody can do to clean up their charge master and that alignment, that's one of the lower hanging fruit ways to really do it, that you can make a big difference in a hurry.
Yeah. And I mentioned early on, we look at the Medicare percentages by department to make sure they make sense. If you as a part of your preparation process, you go through, and what we do is we have revenue codes across the top. We have the departments across the left, or the Medicare cost centers across or down on the left in the columns. And we reconcile those to exactly what's on our cost reports. We're showing up on worksheet C. Then we know exactly where those revenue codes came from and we can assign those. And at the end of the day, my Medicare percentages in those departments should make sense. Once in a while, we will see some issues where somebody's got an override rule in the back of the billing process where maybe 636s are all switched to 250. Now, that one doesn't usually cause issues because drugs are usually assigned in the same spot, and those are both drug revenue codes. But we'll see other things where a 510 gets flipped to a 761, or there's different things that happen from a revenue code standpoint. So, but checking that alignment up front is really important. IV administrations, blood administration oftentimes is getting coded to the lab department, which typically has a low cost to charge ratio, but it shouldn't be because it's a nursing service and it should go to whatever nursing department is actually doing that. And those have a higher charge ratio. And then you validate that based on utilization at the end of the day. The other thing when we do that is we also will reconcile, if you've got the revenue usage there, you can see what usually the revenue usage contains all your accommodations or your room charges in it. A couple systems don't, but most of them have it in there. You can validate, am I actually identifying my days correctly in my statistical reports? We go through a reconciliation process to determine, if those are lined up, that we've actually got similar numbers or they're close. They usually, if you have them on your stat report, you should have billed them for that year. Those numbers should match. If there are differences, you'll want to know why are there differences that are out there. My guess is that I don't see a lot of labor and delivery out there in the critical access hospitals anymore. It's going to be less and less of a common thing to find. But if you do have labor days or labor and delivery costs out there, those labor days, if you get charged a room charge at midnight, the labor cost is in the labor and delivery line. We don't want to include those labor days or those room charges for those days when somebody's in labor in the denominator on our cost reports. We need to remove those correctly. So that's a key part of looking at it. Physician expenses. I'm probably getting too detailed on some of these, so I'm probably going to run short a little on time here. But on physician expenses, as we look at it, really make sure you understand on the ER availability expenses. Do I have good time studies? Do I have the right contracts for ER spelled out from a facility standpoint? Am I giving myself credit for those? Make sure you get medical director expenses in those contracts lined up. So if I'm paying him $10,000 for being a medical director for the facility, I want to make sure I get credit for that. I don't want to just offset those expenses. And I also want to make sure I get a credit for the right spot. So I might have a rural health clinic doctor that I said, I want you to be a medical director over our inpatient unit or over a hospital in total. And we may put those medical director costs in a different cost center than the rural health clinic if they're not just being a medical director in the rural health clinic. And we want to make sure those get to the right spot and get lined up with the right percentage. I think I mentioned recruiting expenses earlier, just watching out for provider FICA taxes. If you've got salaried physicians, we want to realize that the FICA piece is considered an administrative cost. That's allowable. We don't want to include that as part of their benefit packages. And then if we carve out physician costs, or if we've got physicians in the ER or surgeons that we're carving out 100% of the cost, or a straight provider-based clinic, we're carving out 100% of the cost, I would advocate get their actual benefits. Don't try to use an overall percentage when you do that. Their actual benefits for a physician usually range around 10% maybe of their salaries, compared to the average employee might be 30%. If I end up carving out 3 times as much of benefit number as I should, I'm obviously going to leave some dollars on the table from a reimbursement standpoint. I think I'm going to skip this. This is just an example of when you're carving out non-cost-based reimbursement centers, what to look for. What I will say is, anytime you do an analysis as a critical access hospital, there are always 3 things to consider. What are your direct impacts on expenses? What actual expenses am I going to carve out, or am I going to add? What's the direct impact on the revenues? What revenues am I going to lose, or what revenues am I going to add? And then always consider the cost report implication of, what happens to the rest of my cost-based reimbursement on the cost report if I add or delete something. If I add a non-reimbursable cost center, it's probably going to have a negative impact. If I'm removing one, it's probably going to have a positive impact. But the reality is, it matters of what you're actually going to do. You don't want to look at fully allocated costs, because you may not actually cut fully allocated costs. You want to look at the actual incremental expenses that you're removing to see what the impact is from a facility standpoint.
And as you're going through here, Dan, that's always one of the biggest issues that I see hospitals making decisions, looking at, oh, in worksheet C, my total costs are X, and I'm looking at my total revenue and estimating what my net revenue is. Oh, I'm losing money on this department, but you never can really cut the overhead department, the overhead costs. You're not going to lower management, compensation. A lot of times you're not going to change your business office. A lot of those different overhead departments, short of like maybe dietary food costs, things of that nature, they're just really hard to move the dial on. So you really got to look at what are costs that are direct that we can actually impact, and what are direct revenues that we're losing, as Dan was kind of alluding to.
Yeah. So as we work through those, I think those are key pieces to look at. There, when you get the slides, if you want to see, this is an example of just how we kind of look at and pull out an incremental cost center. We're looking at, what am I really, not what am I fully allocated taking out, but what am I really taking out? What would the impact of taking those costs out be overall, and working through it. I'm going to skip through these. So if I think about other impacts and things that are out there, actually, this is kind of in the non-reimbursable cost center, but thinking about time, one thing by the way, to think about, it doesn't mean you shouldn't have non-reimbursable cost centers as a critical access hospital. One thing worth stating here, I think, is, sometimes that's a good idea to have those. Sometimes it's really about serving the communities you're in, and sometimes you have to be the one to do that. It's just a matter of, how do I structure that to minimize any negative cost report impact that's out there. We have had some facilities that have kind of done the opposite of what you'd expect, but because they have such good, loyal community buy-in, they do really well. So you want to look at that. So from a Medicare audit standpoint, we are seeing Medicare audits, and even the desk review is getting ramped up. CMS has been pushing out some additional requirements for the auditors to look at when you're looking at your cost reports, about changes in the documentation of changes and what's happening out there. One thing to think about, and what I would say to people, is it kind of comes down to, you plan, you document, you support, you review it annually, you repeat. And what I mean by that is, when you start your cost report, let's sit down and figure out what changed during the year. Were there different statistics I need to add? It might be 3 months before I start that cost report that I want to think about, what stats am I going to have, and where are those going to fall? What do I need to do? What things do I need to collect? Make sure you're keeping that documentation. The worst thing you want to do is have kept it initially and then lose it. Had a provider that during the COVID years, they were doing ER time studies. It got to 2022. The DON decided to clean up her office, threw out the original support. They got audited a year later, didn't have the original support, left some money on the table, unfortunately, because they didn't keep that support. So document it, keep your support that you've got on anything that you're arguing. Be very careful about that. I would suggest having multiple copies and keep it in a good electronic location. Keep original copies, at least scanned ones, if anything, of some of that backup. And then really sitting down and reviewing your cost report. So you should, before you file your cost reports, you should be sitting down with the preparer saying, what is there out here? What changed? Are we handling it correctly? Is there anything new that we didn't think about or that we didn't communicate? Is there anything else that we can do on this cost report to optimize it? And or might there be something coming up next year that we need to prepare for, maybe a stat change for next year, maybe we've got a new building cost center coming online, something along those lines. We are seeing your traditional common areas from a Medicare audit focus. We are still seeing them hit the ER coverage side of things. We are seeing the Medicare bad debt component that's out there that they're auditing, fairly commonly as well from that perspective. So, the rural health clinic cost per visit piece is one of those that's been out there now for a couple of years as we look at this.
And Dan, there's still 150 hospitals in the country, or rural health clinics, I guess, because some hospitals can have multiple ones, that did not get that COVID exclusion, and they're being limited on their costs to this day.
Because we're working on correcting a couple of those right now. The 2020 year was used to set your limit. If you had a productivity issue back then, we want to make sure you've got those exceptions filed, that you're taking care of those, so that cost per visit limit can be as high as possible going forward. Now that the productivity standards are going away, the way that they read a couple differently. If you look at some of the summaries out there, they talked about cost report periods beginning in 25, but if you look at it, it's the actual standard, I believe, says cost report periods ending after 12/31 of 24, the actual Federal Register. So I think anything that's ending in 25, you shouldn't have those productivity limits in place anymore. So that should be a positive thing going forward. You won't have to ask for those exceptions going forward. We've actually had some facilities ask for those exceptions for 24, 23, and other years, because on the basis that CMS basically said we don't think we should have those anymore now going forward. Other things that are out there that, the past few years to think about, the definition of primary and secondary roads. If I want to have provider-based facilities that are off campus, it used to be they had to be 35 miles away from the nearest other hospital on primary roads, but they didn't really define what primary or mountainous roads and things were. They did define secondary roads are actually, they define primary roads as being 4 lanes, so essentially interstates. So if we're not talking interstates or other 4-lane highways, you really only have to be 15 miles away from another facility to be able to have a provider-based department. So that's come into play on some of our facilities where they've converted some of those off-campus clinics into provider-based departments that are out there. So those are just a few things. I've left a few minutes. I know I went through that one section a little quicker, but I wanted to leave a couple minutes for questions. If anybody's got questions at all on the reimbursement side.
Wonderful. Thanks, Dan, and thanks, Matt, for joining us. I don't see any questions at the moment in the chat, but this would be the time. Feel free to unmute or drop that question into the chat if you do have any questions for either Dan or Matt. I also dropped 2 links into the chat. One is just the Rural Engagement Program website, and then the other is our request technical assistance form. So if anything Matt or Dan said today was intriguing and you thought that it would be beneficial for them to, provide any of that opportunity to you, then please do feel free to get in touch with us, and we can see if you would be eligible for some support. I see something in the chat now, Dan. It says, as a small PPS hospital currently converting to a critical access hospital, this information was helpful. Oh, thank you for sharing. Thank you, Chris, for that comment.
And I would say, yes, you definitely want to think proactively as you set up that first cost report. There could be a lot of dollars on the table here. You want to be proactive thinking through that. And the grant question that Melissa has, how do grants impact the cost report? As you look at it, grants and contributions typically do not need to be offset against expenses in a cost report. I do think on the grants, we need to look at what's the underlying expense. So is the underlying expense something that's allowable? So if I have a grant that's to improve inpatient healthcare or to improve diabetic education or something that I'm doing in the hospital, that cost that's behind that grant is an allowable cost. Therefore, I don't need to offset the grant against that cost from a cost report standpoint. Now, if I get a grant to say, can you put nurses in the public school? I'm going to give you a $100,000 grant to put to have the hospital be the one responsible for putting a nurse in a public school. Well, being a nurse in a public school isn't necessarily in any way hospital based from a service standpoint, directly or indirectly. So that cost itself wouldn't necessarily be allowable cost. And so then in that case, I might offset the grant against the expense to eliminate that cost. So I don't have the non-reimbursable cost out there. But I think you have to look at what's the expense behind it. If it's a grant for charge master evaluations or pricing or reimbursement enhancement or anything like that, those grant revenues, that's all indirectly related to patient care for what you're doing with those. So those you wouldn't need to offset the grant. Does that help?
Yes, thank you. And I just want to mention for our hospitals on here that may have additional questions about their cost report structure or opportunities for enhanced reimbursement, we would love to visit with you outside of this webinar. I know we're 1 minute over and we want to be mindful of your time, but if you want to reach out to the Rural Engagement Program, Cassidy dropped the information in the chat box. We would love to talk with you for our facilities across Texas about how we might partner together with our consultants and with your facility to provide that type of support through the Texas A&M Health Rural Engagement Program.
Hey, thanks, Melissa. If there are any other questions, we will hang out for a couple of minutes. But I want to say a huge thank you to Dan and Matt. I also just launched a poll. It's about 4 questions. It is 4 questions. If you have a moment to answer those, it would be really helpful to us. But we appreciate everyone that joined us today, and we look forward to seeing you on the call next month. If there are no other questions, I think we'll go ahead.
Today I got a question.
Yes.
We had the ER standby. How about inpatient call for physicians? Is that allowable?
So if it's your inpatient for a hospitalist position?
Yeah, whoever the physician or practitioner that's providing the inpatient admissions is also getting a call pay fee.
Yeah, and unfortunately, that isn't specifically covered under the program. That ER visit or the hospitalist type of call isn't covered from a program standpoint. So if you do have hospitalists, though, that you're paying on the inpatient floor, you may want to look at, and I could help you look at this from a regulation standpoint. There could be components of work that you could maybe assign to a medical directorship or some other administrative role. But from a call standpoint, the only availability or call that they will allow for a physician is emergency room call, and they'll typically only allow the one provider in that. From that perspective, I would also say be very careful if your ER docs are also doing hospitalist call. I've seen a few things where you want to be careful how you word the contracts, because if they are covering 24/7 hospitalist and 24/7 ER, you can potentially put your ER call at risk if it's the same doc.
Great, thanks, Dan. Okay, everyone, I think we will adjourn. Thank you so much. Thank you, Dan. We really appreciate it. As always, it's a pleasure when you present for us.
Thank you for having us. We appreciate it.
Everyone. Bye-bye.
Bye-bye.